is the Emergency Medical Minute.
So in emergency medicine, there's a few classic presentations of pain out of proportion to exam. So things like mesenteric ischemia present with abdominal pain that's disproportionate to the exam, compartment syndrome. And then the condition that I was going to talk about is necrotizing fasciitis, which is another sort of classic. Patient presents with pain out of proportion to exam, especially when it's early. So we'll talk a little bit about definitions, the case presentation, and a little bit about the workup and treatment for necrotizing fasciitis. So what's the definition of necrotizing fasciitis? Has anyone seen a diagnosis of necrotizing fasciitis? I'm sure you all have. Anyone can speak to what the presentation was like? So it's generally a extremely severe skin and soft tissue infection. There's generally two clinical syndromes that patients present with, and then we'll talk a little bit about what the operative findings are. So in general, it's broken down into either sort of a polymicrobial infection, generally in patients who have some degree of risk, so they're immunocompromised with diabetes, they're obese, they've had some sort of injury, and then you get a polymicrobial infection, and sort of one of the classic organisms that causes it is Clostridium. So just keep that in the back of your mind because that guides antibiotic choice. The other presentation is for sort of group A strep. Those tend to be a little bit more idiosyncratic in that, a young, healthy host can get that. They also can have risk factors as well, but and that's sort of more of a group A strep that produces a specific toxin that is called M protein. It's a super antigen, and it leads to generally like a toxic shock syndrome presentation, but also the skin and soft tissue infection tends to be necrotizing. So as far as the actual diagnosis of necrotizing fasciitis, that's sort of a pathology or operative diagnosis. So basically, when the surgeon goes in to debride the wound, what they find is gray necrotic fascia, so hence the term necrotizing fasciitis. It has a pretty characteristic sort of dishwater, they describe it, like really foul-smelling, cloudy, liquefied pus. And it's generally something where the tissue, normally fascia, when it's sort of encasing muscle, is really fibrous and thick. When there's necrotizing fasciitis, even with just some blunt dissection with the fingers, it just sort of liquefies and you can break down the muscle. So that's what they find sort of operatively. As far as sort of the workup, it's a classic ER diagnosis because oftentimes it's missed. So what are some of the things that you're looking for besides pain out of proportion? Are there any sort of decision rules that you've ever heard of or features of the history or exam that make you think especially? What are some of the things on physical exam? Anyone? What's that? Crepitus. So it ends up that Clostridium, not group A strep, is a gas-forming organism. So Crepitus, what Ian is pointing to, you feel sort of like Rice Krispies when you press on the skin. The corresponding X-ray finding is that you see gas on the X-ray. Also, other classic things are things like skip lesions. So because it's, it can migrate subcutaneously, you can have a cropping of redness and then somewhere else distal to it, inches away, or so that's sort of a classic sort of skip lesion.
Any rule for CK if they're muscles that thrival? Would they have an elevated CK reliably?
You would not have elevated CK reliably. In general, if it's far advanced, that would be a finding, but the goal is to identify the skin and soft tissue infection as it's sort of evolving into the fascia before there's sort of extensive muscle necrosis. But generally it could be found, but it wouldn't be what we would consider a sensitive indicator for necrotizing fasciitis. I think it would have relatively high specificity because you otherwise would not expect that in a case of necrotizing fasciitis. As far as treatment, sort of predictable that it has broad-spectrum antibiotics, but interestingly, clindamycin is generally added. Clinda inhibits protein synthesis by bacteria, and Clostridium or group A strep, they're both associated with toxin production, which would be a protein. So classically for Clostridium, you provide clindamycin, and then generally it's some combination of Vanc and Gen and Clinda. As far as the prognosis, even with best care, the mortality is about 30 to 40%. So hopefully that gives you a sense of sort of a classic presentation of something in ER that we worry about with pain out of proportion to exam, that has some clinical features, but ultimately requires sort of a low threshold for further evaluation, laboratory testing, MRI if the diagnosis is in question, and early surgical consultation for aggressive debridement and broad-spectrum antibiotics. All right, so that's my spiel. Does anyone have any questions about that?
Emergency Medical Minute is and always will be about free medical education. Medicine's most prolific podcast is successful because of our supporters, donors, and of course, our listeners. Please like us on Facebook and follow us on Twitter. And if you support spreading free medical education, please donate at our website, emergencymedicalminute.com. As always, keep listening.